ready? You got me running.
I am Meredith Hirsh, and this is Working Healthcare. Today, we're talking about a hot topic, and it's about the expansion of nurse practitioners and physician assistants, not just in primary care, but in mental health care and in anesthesiology and across all sectors of healthcare. The truth is, we're at a huge physician shortage right now. And what are we going to do in rural areas and underserved areas and areas where there just aren't enough doctors? So today I invited Rachael Busch-Feuer, who I've known for several years. Her dad is a rheumatologist. Her mom is a registered nurse, and she has lived and breathed healthcare her entire life. We talk about the integration and the teamwork approach for APPs and whether the terminology is APP or mid-level. So I hope you enjoy this conversation as much as I did. Rachael Busch-Feuer, welcome to Working Healthcare.
Thank you so much for having me today.
So your mom was on the podcast about a year and a half ago. Mm-hmm. She was one of my original guests. And your mom's a registered nurse, but she manages the rheumatology practice that you're now a part of. Your dad's a doctor. Why did you decide to become a nurse practitioner?
So the story behind that is I was not a fan of school.
But you did a lot of school.
I did a lot of school. I really practically could have, frankly, gone to medical school.
Yeah.
That's realistically, I could have done that. But somehow I ended up... my grandfather was sick. I was in the hospital. I was watching the nurses. I saw what my parents did, both of them. And I eventually leaned towards going to the medical field. And I was figuring out what I wanted to do. And at that point, I was like, you know what? I'm going to try nursing. And I thought, eventually I think maybe I'll become a nurse practitioner. But part of it, honestly, was related to how much schooling could I handle? And, part of it was my parents had a realistic conversation of me of what it would be to go through. And I ended up settling going that route based on that conversation.
Well, you started school in psychology, actually. Mm-hmm. You went to Emory and you pivoted and you got a degree in psychology.
I did.
And then you went and got a degree in nursing. So yes, as you joked, I probably could have gone to medical school if I added up all of those years. Why did you do that transition?
So that transition was me still figuring out, honestly, what I was doing at that point. Did I want to keep pursuing psychology? I found at that point I really necessarily didn't, and nursing was more the way I wanted to go that route. I actually did apply for nursing school while I was at Emory, but I didn't get in due to a missing part of my application, which in fact was not my fault. But because of that, I had decided at that point I wanted to pursue nursing school after the fact. I took a year where I ended up actually working at a special needs school. Okay. And I worked with kids and I helped to teach and I assisted teachers. So I did a lot of kind of different things in the middle before I went further into nursing school, which is why you have that 1 year gap.
And you're one of three girls. Are your two sisters in the healthcare field?
So my sister is a data scientist.
Okay.
And she's gotten into patents recently, so it's been really cool. My other sister is by training both a teacher and a nutritionist.
Okay, so sort of
by
healthcare.
Proxy. Yeah, we're by proxy.
Exactly, by proxy. I mean, my dad's a doctor and my mom's a social worker, and I tried to run away from healthcare, and now all I do is work in the healthcare field. My hobbies are healthcare related. All my friends are in the healthcare field.
It'll always find you.
Exactly.
It'll always come back.
It tracked me down. I want to talk about the education required to become a nurse practitioner. Mm-hmm. It's a really hot topic, and it's a hot topic in every organization that I'm a part of. I work with doctors. I work with nurses. Mm-hmm. You and I are both in rheumatology. You didn't start in rheumatology, so I want to talk about that transition as well. But what is involved in training to become a nurse practitioner?
So to become a nurse practitioner, I had to get my basic classes before even getting into nursing school. So I had to go back and complete those chemistry, certain math levels, some other things that I don't remember all the exact requirements.
But did you have to do organic chem also, just like med
I
students?
did not do organic chemistry.
Okay.
I did not do organic chemistry. I did basic chemistry as what was required just to get into nursing school. So then at that point, got into nursing school, went through that process, and came out and worked for about a year or so. And I realized at that point that I really just wanted to move forward with being able to do more. While I loved being able to help my patients in that aspect, I was like, I feel like I can do more than what I'm doing.
So you were an RN?
Initially, yeah.
Okay. And so how do you get from RN to ARNP?
So in order to move forward with that, and I think they changed the term now to APRN to be a little bit more accurate. But one of the things that I had to do was I had to go get additional classes again, interview with the school, apply for a master's, and then go further into more schooling in order going through, let's think about pathophysiology. We did pharmaceuticals. We did a lot of the medical classes that you had to go through in order to become a nurse practitioner. And then at that point, it was, do you go to get your doctorate or do you not get your doctorate?
So some nurse practitioners have doctorate degrees. Okay. So it really is a different track. And people have always asked me, what's the difference between a physician assistant and a nurse practitioner? We actually have one nurse practitioner in our practice, 2 PAs. But from my understanding, to be a PA, it's 4 years of an undergraduate degree and then, or a bachelor's degree, whatever it is. And then, I mean, it could take you 8 years, it could take you 3, right? But a bachelor's degree, and then you can become a PA in about 2.5 years of schooling, and it's all on the job training. There's no internship, there's no direct patient care that I'm aware of. Now, when we look at a nurse practitioner, and I know COVID changed a lot of things, but what is the direct patient care involved and how many years of schooling is it?
So it depends on the school that you're applying to. There's a fluctuation depending if it's accelerated versus not. If you're doing accelerated, what happens with that is you are doing your classes during the day, but you're also at the same time doing your clinicals. Usually what I have found in some schools, and I'm sure it doesn't apply to everything, but if you take a longer time period, they'll do didactics first and they'll get to clinicals later. But regardless, you do have hands-on. Now, if you're a nurse first, you obviously have hands-on practical with the patient before you even walk in. And requirements for schools are different, whether you require the bachelor's first, and you're going to require some level of degree or some level of classes before you even walk in order to move forward with getting the degree that you're looking for.
So it's a bachelor's degree, and then it's how many years of getting your master's and then getting your nurse practitioner degree?
So you can do a 4-year BSN, you can do a 4-year master's, you can shrink them down into 18 months for a master's, 2.5 years for nursing. If you're doing accelerated is what I've seen in my experience for that. But accelerated in some ways is a little bit more difficult because you better know how to multitask. And if nothing else, it teaches you how to multitask and how to balance very well because you do not have time. So, it's got pros and cons on both sides, but, it's varying times depending on which route you take.
Do you think that there's a different perspective from a nurse practitioner versus a PA when looking at something clinically?
I think to some degree, there is. I mean, when you look at the basics of it, and it's not just sometimes different requirements. It's a function of they're trained more on the medical model. We are trained through the nursing model, which is a model of caring. So it's a little bit different in how we go through it. Now we're learning the same things, but it's how it's presented is going to be a little bit different on how we do it. And
Did you think of PA school? Did you consider PA school?
I think I'm just biased. My mother's a nurse and my dad's a doctor. I had to land in the middle somewhere.
There you go, right? Happy in the middle, even though you still are the oldest, right? So as a nurse practitioner, did you always think that you would work with your parents, or did you, because you pivoted, you actually didn't work with them for several years. You joined them. Yeah, tell me that story.
So I made sure to get around to different rotations when I was in both nursing school and nurse practitioner. I did a variety. I did OB-GYN, I did cardiology, I did primary, I even tried surgery. I found I still loved rheumatology the most.
Why?
I don't know. He'd just been whispering things into my brain, and I just, I don't know. I really just love rheumatology because it's always about...
It's definitely the cognitive specialty.
Well, that's it. It's the cognitive specialty and being able to help that patient and make sure they can walk out that same day with some improvement and being able to do something to help them and watch them come in a wheelchair and then they walk out, a month later because you got them on the right drug. I mean, being able to do that is something very special. Surgery was definitely not for me. And I found that cognitive made more sense to me more than anything else. And I think, realistically, I was around my parents who I heard them talking all the time about rheumatology, different disease states, different drugs. I always heard it. Even as a kid, that's how I grew up. So for me, maybe that played a role, but now as an adult, it made the most sense to me out of everything. The joke is I was born into it. There was no way getting out of it, but.
I think it's interesting because I've been doing this for 18 and a half years, and somebody else, could they be where I am or have the knowledge base that I have after 18 and a half years? I also sort of was born into it. My dad has severe psoriatic arthritis and psoriasis. And look, my brother's in dermatology and I'm in rheumatology. So there you go. My husband and I met when I was 19 years old. I went through medical school with him, training with him. I always heard the terminology that surrounded and the diseases surrounding rheumatology. And then when the medications came out, the only way we could afford a decent dinner was to go to a pharmaceutical event. So we would go to pharmaceutical dinners when I was younger, and I would learn about the different biologics and the different, I understand the different aisles of drugs, and I know what a TNF inhibitor is. And that is because I knew about it before I started this position 18 and a half years ago. So it definitely gives me an advantage. It must have given you an advantage too.
I can't necessarily say that it did. Maybe in the way that it kind of changed how I think about things to some degree. But retaining everything from that age, because I did go through psychology and I did a whole bunch of other stuff before then, I would say not necessarily. I did start rheumatology from scratch and in that end. And I worked hard to kind of push myself up to absorb that knowledge and to get up to seeing patients.
I did a little bit of research through the Bureau of Labor Statistics because mid-level care, APP care, it definitely is a hot topic. Before I even get into that, what do you prefer to be called? An APP, a mid-level?
So mid-level is usually not one I aspire to anymore. I kind of threw that out the window a long time ago. Because, I mean, come on, you're walking into, a patient walks in and, hi, come see my mid-level today. I mean, do you really want to come in and walk to see the mid-level? For patients, that terminology is kind of cringy, really.
But doctors don't mind it. But if I call you an APP, I've had doctors who have been insulted. And most specifically, I had Dr. Rebecca Bernard on the podcast over a year ago. And she was like, APP, it's not an APP. That's an advanced practice provider. What does that make me? And she thought that it elevated nurse practitioners and PAs above physicians. What's your thought?
I would absolutely disagree with that. That may be her perception, but the goal of the APP terminology was nothing more than to reframe it to just say, okay, we're not just nurses, we are not just physician assistants, we're not just nurse practitioners. We have advanced training. This is not putting us above physicians. You're not calling us doctor. We're meant to work with the physicians. That's our goal. But it's also better terminology for the patient as well to make them feel more comfortable. Because again, who wants to walk into my office and say, oh, you're going to see the mid-level today? And, that didn't always go over so well. So yes, you go with the nurse practitioner, you go with the physician assistant or physician associate, it's the new terminology. But it's really about advancing the term to show that we do have advanced training. But we are not above the physicians. We're meant to be colleagues and teams and to work together. That's all that's really supposed to bring together, but it doesn't put us above physicians.
So let's go back to my statistic because I was looking at the BLS, the Bureau of Labor Statistics, because there's a huge physician shortage right now. We know that the aging population continues to age and grow, and there's definitely a need for medical care. And if you look 20 years ago, there were 39 APPs per 100 physicians, okay? 10 years ago, it went up to 41. Now, actually, as of May 2024, because that's the most recent data, 83 APPs per 100 physicians. So it's almost a 1-to-1 ratio. What do you attribute that to?
Shortage, cost.
So do you think more APPs are going that route or more students are going that route as opposed to medical school?
So I don't know that I can say, I think more students are going that route. I don't know it's necessarily deviating people from medical school if they want to go. I don't think that's necessarily the case. I think it's just opening up another spectrum of say, hey, nurse practitioner and physician associate is an option for you. And there's more people hiring as well. So that also plays a role with this. Obviously the increase in number is related to overheads up. And cost is up, and it's a lot of trying to marry business and medicine. So how do we improve that? So it's really just promoting that team mindset, I think, to really make sure everybody works together, that the patients do get the best care.
Let's talk about that team mindset because that's the approach we take at our practice. This is part of our team. We all work collaboratively. We all work together, and this is what we're doing. And I want everybody be able to work at their highest level. Are you able to see the same types of patients your dad, who's a rheumatologist, can see? Are you dividing up the care? Where do you know that you need a doctor, rheumatologist, versus a nurse practitioner? Where's the line?
So I think it depends on how everybody's trained and what they're comfortable with, and every APP is going to be a little bit different. I do see complex cases, but when I do see complex cases, I'm usually working with my physician on them to ensure that we're following a good plan to go forward with it. If there are any questions, they're absolutely available there, and we see them together. The physicians will decide as they're seeing them how complex they are and if they need to hold on to them up front and continue to see the patients, or it becomes a joint thing. I will see incredibly complex patients, but usually, like I said, it's team, right? So we're usually working together on those cases. I'll be like, okay, this is, I saw the patient, this is what's happening, this is what I think we should do, and this is what I want to move forward. And they'll go, yes, no, let's go see the patient. And so that's kind of how we move forward to ensure those patients get the care they need.
So you are seeing patients with a rheumatologist in the clinic, or do you also take care of patients when a rheumatologist may not be available?
I'll see them when they're not available. When there's no physician in the clinic, we will absolutely see them as well. There's nothing stopping us from doing that either. I'll see a variety of patients. Sometimes, we ensure that the patients are seeing, the physician once a year, so they check in with them. If there's anything that changes, we check in with them. If there's anything significant that comes up. But in terms of the complex patients, that's definitely where we're looking for that team-based, but we'll see them on our own too.
Yeah, that's where I'm really struggling with my mom. My mom's really sick right now, and she lives in the panhandle of Florida. She moved about 2 years ago, and trying to get in with a cardiologist has been futile. And I called, I shared this on a previous podcast episode. Maybe if I share it often enough, a cardiologist in the panhandle of Florida will call me and reach out, www.meredithhirsh.com, but reach out to me and say, hey, I can see your mom. But I have called and tried to schedule her, and there's a 4-month wait. And it's a struggle because my mom's been in and out of the hospital, and they offered to allow expedited care with a nurse practitioner. My concern is my mom's disease state is such that I'm not comfortable seeing a nurse practitioner. I have seen nurse practitioners often. I love the nurse practitioner in my practice. The 2 PAs who work for me, they see me. I refer patients to them depending on the disease state and what's going on with the patient. What do you do in situations like that? Because we talk about opening up the ability to provide care in rural areas, in areas where there is such a delay and a lack of physicians, so that patients can at least be seen by a healthcare professional.
So I don't actually think for when you have a rural area that you're dealing with, I think, and you got to remember why nurse practitioners were created in the first place. It had to do with a shortage of pediatricians in rural areas. So, and that was started in Colorado. So is there an issue with seeing APPs up front? I do not think so, with typically the physician seeing them on the second visit, or if you need a phone call, make a phone call. Like, I personally don't have a problem seeing complex patients, but we always try to do team-based approach as much as possible. In getting people into rural care, the fastest way you're going to do it is through the APPs. But that's also why most of them, at least that I know in rheumatology, have someone they can call when they do have a complex case. So it's not like we're all, or if they don't know a physician, they have a whole group of very advanced APPs that have been doing this 30, 40 years, you know, that they can reach out to, that also where there's groups. I mean, that's where community is huge in the rheumatology APP arena, because we can actually talk to each other as well and be like, you know what, I'll give you an answer, or let me ask my physician, or let me see what we can do with this. Oh, this is an interesting case. Let me see what we can help you. So sometimes, and there's different ways you'll do it. I've seen where APPs will actually be the first visit in a practice, and then the physician will visit them on the second visit. I've seen it that way as well.
I think that's a really great thought process, because if you have a delay in care, it's much worse for the patient than being able to see a nurse practitioner or physician assistant.
Let them get the workup done.
That's what I'm thinking. I'm just thinking about it, and on the business side going, how can I implement something like that? Because we have 3 APPs. Alexa is a physician assistant who works directly with my husband, and she triages every new patient, but on an office visit, a new patient visit with Dr. Hirsh. So she does the triage because she has that ability and training and mindset, and she's worked hand in hand with him for so long to be able to dig down and summarize it for the doctor, so the doctor's not spending a half an hour gathering the information, and it allows him to see more patients.
Yeah, and that is a fantastic way to do it. In our office, for example, we try to limit I shouldn't say limit, but what we do is we give the new patients to the physicians, and we have them start there, and then we pick up with the second visit and see them with the physician.
And that's what I was saying was happening with Alexa. They see the doctor, or at least in his situation, they're scheduled with Dr. Hirsh. Alexa does the triage, and then Dr. Hirsh goes in. And then at that point, he decides, do I need to keep caring for you, or is it osteoarthritis and you need a knee injection? And that's something that Alexa can certainly handle. So I think it's a different perspective. Definitely the one-on-one ratio, or the one-to-one ratio, is really helpful to be able to expand the number of patients that you see. In Florida, it's a huge topic. I go up to Tallahassee and do a lot of advocacy work. I know that you're highly involved in all of the organizations I'm involved in regarding the Florida Society of Rheumatology, the National Organization of Rheumatology Management, CSRO, right, our coalition of state rheumatology organizations. And there's a fine line, because I was just up with the Florida Society of Rheumatology in Tallahassee, and there has to be a cutoff point at some time when you just allow open access to APPs to care for patients on their own, which is what was happening in 2025, and the bill ended. Now, in primary care, APPs can treat patients without the oversight of a physician. I should say specifically nurse practitioners. Sorry, not PAs, nurse practitioners. What are your thoughts on that?
So they do have a physician, and there is actually a committee for oversight with them. So it's not just getting that. They do need a special license for that as well.
Who's they? The nurse
The nurse
practitioner?
practitioners.
Okay.
Yeah. When you've been doing this 20 years and you've been out and you've seen patients, I have seen, I'm going to probably maybe a little unpopular, but I'm going to say it anyways. There's good doctors, there's bad doctors, there's good NPs, there's bad NPs, there's good PAs, there's bad PAs.
You're right.
And it has to do with the people.
It's not unpopular, Rachel. We are not commodities. Not we. I think of myself as I'm not a doctor. You are not a commodity. Doctors are not commodities. Some are great and some aren't as great.
And so it comes down to, I have been blessed, and the people that I know have all been amazing. They have all been amazing. And a lot of the people that I've seen that have gone out on their own have had a lot of experience, and they know their patients, and they know what they're doing, and they are on top of it, and they've done an amazing job, is what I have seen so far.
But how do you limit those who don't have that experience? I'll give you this example. I teach at Florida Atlantic University, and I teach a medical business management program. And I have students, because it's an executive education, who have a high school diploma and those who have a medical degree. And I've recently had a lot of nurse practitioners in my class. And I always ask on the first day of class, why be in a certified medical business management program? And they've all said, I want to open up my own practice and I need to have a better understanding of the business side. And oftentimes they're coming from another country, and they may have, some have worked as doctors and have foreign medical degrees and have come here and fast-tracked their way to become a nurse practitioner, and now they want to practice in some way. And others are opening up an aesthetic clinic because, you know, the world needs more Botox. So where's the fine line, Rachel?
The fine line, I don't think, is going to be that black and white, but it's got to be experience. And they, you know, I know they have to have this special certification in order to get there.
What is that certification?
It's a, you're going to ask me, and I'm going to
I don't know.
Right,
I'll look it up. We can look it up, and I'll definitely have it in the show notes to be able to give details.
Yeah, I believe they have to get like a second, it's not a certification, I think it's a license actually, in order to work on their own. And there is oversight there. There is oversight. But because I'm not necessarily, I would say, the expert on that part of it, just because I'm not the one to get it, because I work in rheumatology. I'm not looking to go out on my own. I'm happy to be working with my doctors and happy to be dealing with my patients there. But there needs to be a certain amount of experience. There needs to be a certain level of expectation of what they can or can't do. That just has to be put together in order to do that. I mean, coming out right out of school and going and practicing on your own, I don't know that I personally would suggest that. Having done it, you know, I worked in primary care. I worked in pain management. I've done different things. I don't think I would have gone out and worked my own without having gone through that experience.
And what I think is super cool about being an APP is that you don't have to stick to a certain area of training. So if you're a doctor, you go through your residency and then maybe you go for your fellowship, but your father, my husband, cannot decide all of a sudden they want to practice cardiology.
There is that.
They did internal medicine and now they did rheumatology and they are a rheumatologist.
I mean, they could. They just have to go out and get board certified again.
Exactly.
10 years later.
Right. But you have the option to actually pivot from one specialty to another. And you didn't start in rheumatology.
No.
So why did you choose to make that pivot? I know we talked about your pivot into rheumatology, but why didn't you start straight up in the rheumatology world?
because I was told I can't.
You listened to your dad.
I did.
I did know that story, though, but I wasn't going to be the one who said it.
Yeah, I actually was told no. And you know what? I'm glad that was that I didn't, because really I got to see a wide variety. I worked hospital, I worked nursing home, I worked primary care. So I saw a wide variety. I even did pain management. So I got a large variety of experience before walking in, which frankly, it helped quite a bit walking in, because realistically, we're dealing with every organ system. So you better know from a primary care standpoint what the heck you're looking at. And school is great. School gets you to starting point. Then you have to go into real life.
And then that's when you have to learn. And in 2025, the bill in Florida died on the, I'm trying to remember, it died in the House. The Senate, it passed through, but it was for autonomous practice for APRNs in mental health services. And this has been a really hot topic since COVID. And I share this because I have a lot of listeners who have wanted to discuss this topic, because they can go online or they can meet with an APRN and online, depending on state rules, and get a medication refill for ADHD or for depression or for anxiety. Florida isn't allowing that for APRNs, but in other states it is. Do you think that APRNs have the ability to provide mental health care? Is this a bill that you think should have passed in Florida?
So I think with any autonomous practice, when you're looking at it, there needs to be requirements set as to experience levels, as to testing to achieve that, as to extra licensing, whatever it may take. I truly believe that just to make sure that you are able to go do it. I mean, everybody, it's great to go out and work on your own. It is exciting, but there has to be definitely that learning point. And sometimes, fellowships would be good, more fellowships for all APPs. It doesn't matter what specialty. That's always getting in more of that experience. That's why you go and work.
Do you have to get testing every few years or continue for your accreditation or credentialing or however it works, like doctors? I know for rheumatologists, they have to do it for rheumatology and for internal medicine if they want to stay double board certified.
So you're talking about the certifications or the licensing?
I guess I'm talking about certification. Licensing, how does that differ?
Every 2 years. We have to renew with the Board of Nursing.
What does that require you to do?
Usually that requires CME.
Okay.
Certain ones that they require by the state.
Okay. Any type of additional testing?
So no testing for NPs, unless you let it lapse, but we usually do every 5 years. Is you have to show you've worked a certain amount of hours, and you have to have another certain amount of CMEs for continuing education as well. But we have to renew every 5 years.
I want to share 3 big Florida 2026 agenda items right now that are creating additional pathways for APPs in the state of Florida. I'd love to hear your perspective, because I think you're reasonable. I think you're rational.
Thank
I know,
you.
Isn't that nice, Rachel?
I'm so reasonable. Hey, Mom, are you hearing
exactly.
this?
I was going to say, Stacey, did you hear me say that? Because I like what I'm hearing in the sense of it is a team environment.
Yeah.
APPs work with the doctor. It's not just hanging a shingle and taking care of all of these subspecialties. It requires you to have a certain number of years of experience and to prove certain benchmarks to be able to care for patients.
And to be able to practice on their own at that point. You know, it's not that they can't. I've seen great NPs that have helped me where other people couldn't. And like you said, you've seen NPs where they're fantastic providers and some of them do practice on their own. That's okay. It's just making sure that they've done it and having basically those guidelines.
Yeah. And show competence.
Yeah.
Let's talk about the 3 items right now that are sitting in the Florida, with our legislature. We have SB 668. So that's for physician assistants. So it would create a registration pathway for PAs to practice without physician supervision with an effective date of July of this year if passed. It was just introduced January 13th. And this is similar to what NPs or nurse
Would they
practitioners.
have an oversight board as well?
Correct.
Okay.
What are your thoughts?
It's the same thing. It's where there's no reason PAs cannot do that. It's just having that, making sure they have that oversight, meeting those benchmarks, and making sure they're able to do it on their own. You know, they've been doing it 20 years.
Should it be limited to primary care?
So I know initially it only was limited to pretty much a primary care rural areas is what they were looking at. Is this just a general for everybody?
I don't know. This is what I'm seeing. It's very general. I think it needs to be dug down and be limited to primary care or in rural areas.
So typically that's the way they start with these things, is in a rural area and a primary care to start with to get people in. It starts getting a little bit more difficult, I would say, when you start getting into the specialties at that point, because you need to have that training, making sure you have those benchmarks and making sure that you have those relationships, certainly with specialties for sure. And now, to be fair, in some states I've seen rheumatology APPs work on their own without a doctor. And I know one in one state, but I
know two in the state of Florida. We were having a whole discussion at the Florida Society of Rheumatology about this. I don't agree that that is accurate. There's so much training involved to become a rheumatologist. I think it dilutes the specialty and ability to properly care for patients. I like the team approach.
So what do you do in a place where there's not enough rheumatologists?
That's where the struggle is. Look at what I'm dealing with my mom with cardiology.
So that's the point, is we need to think about other ways to do it. So making sure, for example, the person that I happen to know is out in an area where there's not as many rheumatologists. They can't get in and they're still dealing with weight, right?
So let me tell you what I'm thinking, actually thinking through this with you. My mother's primary care physician, her internal medicine doctor, is actually taking care of her cardiology needs until she can get in. I will tell you, I think I'm more comfortable having an internist who is a physician care for her cardiology needs over a cardiology APP.
So I think it's also hard. How long has that APP been working?
I don't know.
Well, that's it. So this person could be working for 20, 30 years and been working with that person. Would that change your mind in any way?
Probably. It probably would.
Now, I'm sure you would still feel the same way if you come out, they've been working for 6 months, and you'd be like, I mean, I would understand that. Absolutely. Especially with somebody who's more complex. But I think it's not so black and white as trying to blanket everybody and taking their history and amount of experience into consideration rather than just blanketing it as no.
But I also think, Rachel, it has to do with the type of training.
Correct.
I would want to know who was training that APP, what type of oversight was provided, because I've interviewed APPs when I've recruited for more, and I'm actually going to soon recruit for another APP. And the big question is, do I want a PA or do I want a nurse practitioner? That's a whole nother, we can talk about that too. But I interview people who have practiced for 20 years. But they literally have essentially practiced on their own. While they've had the, quote, oversight of a doctor, they are actually not working in coordination on a care team. I'm not comfortable with that because and again, it's person by person, my APPs will tell me, or not me, tell the doctor, bring the doctor in. They know their skill level, but my doctors do the same thing. They are always communicating with each other. I have doctors who specialize in one area of rheumatology versus another. So I have somebody who has a positive ANA and wants to see Dr. Hirsh. I'm like, no, you don't. No, you don't. You want to see Dr. Ludeau or you want to see Dr. Limpel because that is their niche and that is what they love.
And so that's one thing that in our practice, well, a couple things. Let's start with this. Standardization of training would be super helpful in specialties. Standardization, number one. That would be huge, I think, in order to kind of move forward the APPs helping with physicians and helping in those rural areas to really, I think, make a bigger difference. Number one. That's piece number one. Piece number two, everybody should specialize in something. That was one of the first things I was told is find the thing you love and learn about it. Now, you should still know generally everything, but find the thing you are good at and learn about it.
Oh, yeah. It's the 10,000 hour rule, right? Takes 10,000 hours to become an expert. So this is back again. So this is the second bill in Florida. Again, we're looking at expanding APRN autonomous practice to include providing mental health services. This is getting pretty far along.
Well, I think there's going to be so many reasons for this because I'm finding more people are needing mental health services and they need access to it, and it's not always affordable. And you have these companies that are utilizing NPs to help fill that gap. So what are you going to do when you have a shortage or it's unaffordable and you have these people hanging out there? How do you balance?
Oh, you can't get a child psychiatrist in this area to save your life. And if you do, they're charging an arm and a leg and they don't take insurance.
So they're giving you a way to work around that in order to open up the ability for people to see more APPs and giving access because, I'd love to say everybody's hiring all the time, but that's not always the case. And I actually haven't looked at the numbers if there's a surplus of mental health APPs that could also be driving some of this too.
So here's a big one, nurse anesthetists.
Yes.
This is a hot topic, and Dr. Hirsh spoke about this specifically on my first podcast of the year when we talked about looking back at 2025 and what we're looking forward to for 2026. And he says it keeps him up at night and he gets a little scared about it. He does not want only a nurse anesthetist who is overseeing care and anesthesiology, but this would expand the autonomous practice for nurse anesthetists. What are your thoughts?
Autonomous nurse anesthetist.
Say that like 3 times fast. I can barely say it once.
I feel like a nurse anesthetist, really it should be, that's more of a team effort to do that because, I've had that. I had a great nurse anesthetist, but I know the anesthesiologist still came in and checked on in the middle of my procedure. This
is autonomous care.
Yeah, and I get why he's saying that. I do. But again, I am sure it's the same. You're going to have these people with a lot of experience who do really well, but you have to set those benchmarks. If it's free for all and no benchmarks are set, that's when I get concerned. That's really when I get concerned.
Rachael, we're wrapping up, and I want to hear, before I ask my final question, which I know you know what it is, I want to wrap up and give you the platform to share anything that you would like to share about nurse practitioners, about APPs, about the teamwork involved in your place within our healthcare system.
So I think really we're here to help. APPs are here to help with their physicians work together. We have the capability to work autonomously, but it's really, it's a group effort, especially in specialty, and we're fighting a shortage of physicians. You got to fill it somehow. So we're here to help, and I think we're qualified to do so. Remember something, a lot of us, we were nurses first. We have that caring, we're compassionate. We really try to take care of our patients and handle that. We get creative. I'll give you a fun example. So for me, I started finding that I'm having a great number of women with neck and back pain. And I'm like, what is going on? And they're going for procedures and this and that. Well, I did a lot of research and come to find out they're wearing the wrong bras.
Oh.
Yeah. And I've developed a new measurement in the office, and I am fixing these women as they come in, and they leave like 50% less in pain or no pain. So it's about getting creative, and I've seen a lot of NPs get creative, even PAs. We have to get creative with what we got in coming up with new ways to help our patients and understanding different things. And I think we do have a lot to offer. And I hope you all learned something new about this because I am sure this isn't talked about much. But, it's definitely about finding the best ways to help our patients and to bring them some sort of relief, whether it's pain, helping them with their joints, helping them with their inflammation. We're capable of doing so and working with the physicians, or we're okay on our own to be able to do it. But the physicians also have to work with us to train us as well as we're going through that process when we're new. It's a joint effort. Both sides have to put in the work, but when we get there, it's an amazing relationship, and it's beautiful to see because then we can just help more people.
So now we're going to end with my final question, Rachel. If you could create one change within our American healthcare system, and I gave you a magic wand right now, because it's all about fixing the American healthcare system, right? And learning about the inner workings, what would it be, Rachel?
Get rid of prior authorization.
Everyone says that, right? No, it's true. Prior auths.
Prior auths are a problem. I think realistically, the insurers have to listen, as do the PBMs. If they would actually listen to the providers, we'd actually be able to work together to develop a different kind of healthcare to ensure patients get treatment faster and not dealing with the waste of time called prior authorizations and increasing in costs. And it would be more effective for the patient so we don't have to wait. There's no reason for a patient to walk into my office and I can't do anything because you want to save money. It makes it a little tough, and if we didn't get the approval for that because they're HMO only. If we had these conversations and everybody was open with a listening mind, I think we could develop a better way for healthcare.
Rachael Busch-Feuer, thank you for joining me on Working Healthcare. If this conversation hit home or made you think a little differently, don't keep it to yourself. Share the episode, tag a friend, or post about it on social media. Connect with me on LinkedIn to keep the conversation going in between episodes. If you've got a question, an episode idea, or someone you think I should feature, send me a note at meredithhirsh.com. Thank you all for the 5-star reviews. They help more listeners find the show. New episodes drop every Tuesday. Subscribe so you don't miss what's next. Tune in weekly as we explore the inner workings of healthcare, because you can't fix what you don't understand.